Hi, this is Brian Kim. I'm going to share with you this case of a patient with aniridia and a 2+ dense lens and zonulopathy. Because there's very little iris, this is going to show a beautiful display of anatomy during cataract surgery. It'll also highlight the zonulopathy during hydrodissection. You'll see the tension on the zonules, and when the last pieces of the cataract are removed, you'll see that the posterior capsule comes forward, and you'll see how I'm able to deal with this and still have a very safe surgery, very controlled, by doing a no rotation technique with the way I do the lens disassembly, and then using my second instrument to protect myself from the posterior capsule. I use a corneal marker to help me center and size my rhexis. I use a cotton tip to help me do these manipulations, and as well as making my paracentesis incision. I make the paracentesis incision flat to the iris plane, parallel to the iris plane. You need a nice corneal shelf to get a nice self-sealing corneal incision. I'm going to inject some intracameral lidocaine and epinephrine, and then some intracameral dispersive viscoelastic, and then I'm going to do my triplanar corneal incision. I'm going to use the cannula to hold the eye, and then I'm going to make a vertical groove. I'm going to go into the groove, tunnel through the cornea, dive down, and then enter the anterior chamber, and this is my triplanar corneal incision. I'm going to go through the incision, and then with a puncture technique, puncture the center of the capsule, pull downward into a slight C-shaped configuration, create a flap, and then start going around circumferentially to do my rhexis. In a case like this, there is absolutely no landmark to help you size your rhexis because this patient has no iris. And so it's very easy to either go too small or too large. And so using a corneal marker is quite helpful, which will help standardize your capsulorhexis size. But nonetheless, in this case, you can feel a little bit of zonular weakness as I'm doing the rhexis. It tries to come outward a little bit, but I'm able to complete it very nicely, and then I'm going to decompress the anterior chamber. Begin the capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator underneath the anterior capsule, flat, and then rotate the tip down. You get a nice, beautiful wave. You can see so clearly the fluid wave because there's no iris here. As I decompress the bag, you can see there's quite a bit of zonular weakness here. I'm able to spin the lens, but you can see there is quite a bit of torsional stress on the zonules. Again, difficult to say, is this due to zonular weakness or just simply that I'm able to see the anatomy so clearly? I'm going to lift the incision and go in with the phaco tip with irrigation off to minimize Descemet's trauma. I'm going to try to remove the surface epinuclear material, but you can see there isn't any. So this is a very sticky lens with a very thick epinuclear material. I'm going to begin the double chop and cross chop. I'll place the chopper out to the contralateral equator and then place the phaco tip more vertically subincisionally. Both instruments meet in the middle and crush the lens completely in half. You can see this is a very zonular friendly technique. I place the chopper out to the contralateral equator underneath the anterior capsule, pull the chopper centrally, and this crushes the right heminucleus. Again, I didn't require any spinning of the lens during those maneuvers, and now I'm able to attack that first quadrant. You can see as I'm using high vacuum to try to suck that first quadrant out. Number one, the quadrant doesn't want to come out because it's very sticky, but even just with vacuum, you can see how the lens was pulling towards me and the zonules in the bag was moving quite a bit. Again, difficult to say because I'm able to see everything so clearly. Is this a little bit of zonulopathy, or is this just me being able to visualize everything so clearly? I do think there is some zonulopathy here, as I will show you at the end of the case. So now I'm going to attack the second quadrant, place the chopper underneath the anterior capsule, rotate, and then crush the second quadrant in half, breaking it into two pieces, again using mechanical fracturing forces, and then I begin to emulsify each piece separately, crushing and sucking as I go, again to minimize ultrasonic energy, and only using the high vacuum once I have small bite-sized pieces. I always try to preserve a little bit of epinucleus to help protect me from the posterior capsule, but as you remember, I was not able to really create an epinuclear ridge in the beginning of the case. And so I remove all the epinuclear material, I spin the lens in front of me, and I'm going to try to place the chopper underneath the anterior capsule, but also I'm trying to get underneath the epinuclear material so I can get around that and create a separate epinuclear separation, but I couldn't. So I just went ahead and chopped the entire piece. Again, you can see this is a very adherent epinuclear material to the endonucleus. I mechanically fractured the third and fourth quadrants, separating them, and then now I'm using mechanical fracturing just to crush that third quadrant in half. I'm being very ginger and very careful, using the chopper to help separate each piece and then emulsifying each piece separately once they're small enough. Again, I'm placing the chopper and the phaco tip around each piece very gently, crushing the lens pieces and just using intermittent bursts of vacuum and a little bit of ultrasonic energy as needed. You can see this is a very controlled technique. The chamber is completely stable. The posterior capsule is far, far away from me as I'm doing these maneuvers. I'm attacking the fourth quadrant now. I'm placing the chopper around it and then crushing the lens material between the chopper and the phaco tip. And then I'm crushing the lens pieces using mechanical fracturing forces and using, again, mechanical fracturing forces to crush the pieces into smaller pieces, and then using ultrasonic energy and high vacuum as needed. At this point, I believe that whenever I'm using the high vacuum, I feel that the posterior capsule is not quite reliable and stable. And so I'm very ginger at this point, and I decided to put some dispersive viscoelastic into the capsular bag to push the posterior capsule back during the last removal of these last pieces. And then go ahead and place the chopper in now, and then just very carefully with the chopper deep, I'm able to remove each of those lens pieces without worrying about the posterior capsule trampolining upward. I'm pushing BSS into the eye, and as I'm pushing BSS, I remove the phaco tip and then place the INA handpiece. This helps just to maintain some level of chamber stability. Begin the cortical removal here, and so you can see there's not much cortical material left. You can see the cortical material came out quite easily. There's not much there. I'm going to start to polish underneath the anterior capsulorhexis edge, and to make sure the lens epithelial cells are removed as much as possible. In cases like this, you don't want to use high vacuum to polish because you can actually grab the anterior capsule and actually tear the zonules or create more zonular stress. I like to push BSS into the subincisional capsular fornix to make sure all the cortical material is removed. And in this case, you can see there's some cortical material that's liberated with the pulses of BSS through my paracentesis incision. I continue to polish into the capsular fornix, and then I remove that last piece of cortical material. I push some cohesive viscoelastic into the capsular bag, and then I use my sweep to sweep and polish underneath the anterior capsule edge to remove any lens epithelial cells. You can see as I do this maneuver, you can see the retina being highlighted with the light microscope. It looks like the optic nerve, but it's not. It's actually just the light on the retina. So it's a little bit of a fascinating view being able to see that. It's a little bit distracting when you're polishing and during your cataract surgery. I go ahead and widen the incision here because this is a high-powered lens implant. And once I widen the incision, I'm going to inject this high-powered single-piece acrylic lens into the capsular bag. Once the lens is in the bag, I use the INA to help place the lens in the proper position. I make sure each haptic is free of the optic, make sure the leading haptic is in the bag, and then I try to go underneath the lens, and then I'm going to rotate it 90 degrees clockwise, and this allows the entire lens to be spun. I can ensure that both haptics are in the bag this way. By going underneath the optic, I make sure all the viscoelastic is removed from within the bag, and then I'm going to polish and remove any lens material underneath the anterior capsulorhexis edge here. Interestingly enough, I feel like the single piece acrylic lens, the haptics are actually providing some counterforce within the capsular fornix. You can see that the haptics are not fully displayed out, and they're actually crimped a little bit, which again is because the capsular bag, capsular fornix, is keeping the haptics on tension in that manner. And so this is a little bit of an interesting view since there is essentially no iris. Once all the viscoelastic is removed from the eye, I make sure I pulse some BSS into the angle and then push some more BSS and then quickly hydrate my incisions, and that's the end of the case. So you can see that this patient has aniridia This is a beautiful display of the anatomy of the zonules, the lens, during the cataract surgery. You can see there was a little bit of zonular instability during the case as well, but by using double chop, cross chop, mechanical fracturing techniques and doing a very gentle no spin technique, using mechanical fracturing forces to crush the lens material into smaller pieces, minimizing ultrasonic energy, I'm able to do this case with minimal manipulation in a very gentle situation. And you can see that this patient has a very clear cornea, a well-centered lens. I should say that I did offer the patient to have an artificial iris, but due to insurance and cost issues, she declined to have the artificial iris. I think this would have been an excellent option and choice for this patient. But nonetheless, this patient did well and she was quite happy. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.